Shivanduri, and I'm the co-events director for Medvocate. For people that are new here, Medvocate is an organization that aims to help students navigate their path in the healthcare field and learn more about different experiences by connecting them to various healthcare professionals. We've recently introduced the virtual shadowing sessions, and today is the second one. There will be case studies presented to you so that you'll be able to learn just like in an in-shadowing experience. And in order to get the virtual shadowing certificate, please fill out the Google quiz that will be sent in the chat at the end of the session. And in order for you to get the certificate, you have to get 2 out of 3 questions right. And this will close within 2 hours. So please make sure to fill that out, and there will be no retakes or anything. So make sure you really pay attention and listen. Before we start our session, I just want to ask you guys a quick question so we can better gauge your audience. Please type your name and like what school or college you're from in the chat, just so we know who we're interacting with. So I'm very excited to introduce Chrissy Massaro. Chrissy is a certified registered nurse anesthetist in Philadelphia, and she is currently working in an academic medical center and university. Throughout the presentation, if you guys have any questions, please type your name in the chat and wait for Chrissy to answer your question during whenever she has the Q&A sessions. So welcome, Chrissy. Thank you so much for giving your time to speak today, and you can start when you're ready.
Okay, hi everyone. So I'm excited to be here and talk with you guys. Since I can only look at the chat or share my PowerPoint with you, like either or, I can't do both at the same time. I'm gonna just start out by telling you like what a CRNA is, why I decided to become a CRNA, and how to become one. And then we'll pause and I'll respond to some of your questions, and then we'll move on and get into the case studies. So if something pops into your head, feel free to put it into the chat. I just won't get to it for a few minutes, but we'll catch back up. All right, so let's begin. Let's see if I can do this. There you go. So first of all, what is a CRNA? CRNA is a Certified Registered Nurse Anesthetist. Now, there is also another acceptable term that has just come on scene. Some people are calling it a nurse anesthesiologist as well. I'm not going to get into the politics of that because it's a little bit sticky, but just know both terms are now acceptable. So whichever one is easier to pronounce, you can use, and both are technically correct. Although most people will still be using the term nurse anesthetist because that's been our name since the early 1900s, late 1800s. So a CRNA is a person who gives anesthesia. We are in all 50 states in the US, I think 10 different countries. We are the primary providers of anesthesia for the US military as well, and in rural areas, but we're also in almost every big hospital. Most big hospitals use an anesthesia care team. So there will be a nurse anesthetist in the operating room giving the patient anesthesia one-to-one for the whole duration of the case. And then a physician anesthesiologist will oversee multiple operating rooms at a time with a CRNA in each room. So that's the kind of environment I work in as a nurse anesthetist. I'm in a large academic medical center. I do almost every kind of case except for OB, cardiac, and pediatrics. We just don't have peds in my hospital. But next year, we'll start doing a little OB, and I'm hoping to get on the cardiac team next year as well. CRNAs can work in any kind of operating room. All right, so how can someone become a CRNA? It's pretty straightforward. First, you need your Bachelor of Science in Nursing, and that's typically a 4-year degree, but there's also lots of different programs if you already have a different major or a different degree. So there's a lot of second degree BSN programs. Some people get their associate's degree in nursing first and finish their bachelor's later. But to be admitted into a CRNA program, you have to have your BSN. Then you typically need at least 2 years of ICU experience. Most CRNAs have 3 to 5 years of ICU experience before going back, because critical care is like our foundation for anesthesia. There are schools that will allow you to work for a year and then apply after your 1-year mark, because typically it's a 1 to 2 year wait list to actually start the program from the time you apply. So they figure you'll have at least 1 or 2 more years of experience by the time you get there. Oh, and then of course I should have told you, it used to be a master's degree program. All the programs are switching to doctorate degree programs now. So by 2022, every program will be a doctorate. Most of them have already switched over. They're typically 3 years long, and it can be either a DNP or a DNAP, Doctor of Nursing Practice, or Doctor of Nurse Anesthesia Practice. It's essentially the same degree. The DNAP will have a few research classes that like are a little bit more anesthesia focused. The DNP, you might like share those research courses with nurse practitioner students. So that's really the only difference, but either one will prepare you for anesthesia. The anesthesia content does not change and your clinical content will not change. It would just be your doctorate courses that might be slightly more tailored to anesthesia. So there you go. So I did not know that I was going to become a CRNA. I'll talk about my journey and how I stumbled into this career. Like many of you, I knew I wanted to go into healthcare, but I wasn't really sure what I wanted to do. I kind of had thought the options were doctor or nurse, and neither of them. I didn't really want to be a nurse just because I had a misconception of what nurses were. Nurses aren't really well represented on TV or in the media. You know, most of us, I think, at one point in our lives have thought that unless you had a family member that's a nurse, you think that they're just like handing out pills and like fluffing pillows. Like you don't really realize how much nurses know and how much nurses actually do. So I didn't really understand that. And then when it came to medical school, I was thinking like, oh, maybe I'll be a doctor. But my family really discouraged me from it. I have a cousin that's a PA. She's like, oh, like, you know, my aunt's a nurse. Like, oh, they were saying like, you know, doctors say like they work so much, they never get time with the patients. That's not really true. Now that I work in healthcare, I see that it, you know, a physician can absolutely have meaningful patient interaction. That's totally a stereotype. That's not true at all. You can have as much patient interaction as you want as a physician, especially if you pick different specialties. But that was like what was told to me at the time. So it's like, oh, well, I don't want to go become a doctor and never get to see patients. So what can I do? Again, those were both misconceptions of the healthcare field. But so I ended up doing pre-med and kind of just like keeping my mind open to things. I got my bachelor's of science in psychology. I minored in biology and Spanish. And then I studied abroad in Mexico and did a pre-med internship there. So when I was in Mexico, some of my paperwork fell through. My university didn't like send everything they needed to get me approved for the hospitals. So I only got to go to 2 of the 4 hospitals. And I only found that out when I got to my second hospital, that my paperwork was not going to be accepted by the last 2 hospitals. So a anesthesiologist there, her name was Doctora Elia Fernandez, and she took me under her wing. And she had me shadow anesthesia lots, but she helped me get other experiences too. She would ask other doctors to like let me work with them. So I had a really positive experience with anesthesia. I thought it would be so boring, and I ended up loving it. It was a women's hospital, a public women's hospital. So they did free procedures for women who were in need. So I thought it was like a really beautiful thing to be bringing like comfort and pain management and care to these underserved women who were afraid, who had delays in care due to, you know, their poverty, some social stigmas that were going on, just like different things that happen, not only in Mexico, but around the world and in the US as well. So I thought it was really cool that anesthesia could be part of that. I had no idea. So I came back to the US and I was like, okay, like maybe I'll go to med school after all. I still don't know. Let me get a part-time job in the healthcare field. So I worked as a nurse's aide in a surgery center. And again, one of the people that kind of mentored me there was an anesthesiologist. And the anesthesiologist, he oversaw 6 operating rooms, a CRNA in each room. And he spent a lot of time out in pre-op talking to patients. And he had really good, he was really, really good at like helping them feel calm and comfortable and explaining things to patients. And he loved to teach me, and he would ask the CRNAs to let me shadow them as well. So I had all these cool experiences. And that's where I discovered CRNAs. And so both him and the CRNAs both encouraged me to go to CRNA school. So I did a 2nd degree in nursing at Thomas Jefferson University. It was an accelerated 1-year program. And I was very, very lucky to go straight into the ICU. And I still kept my mind open. I was thinking like, maybe I'll just stick with bedside nursing. Like this is so much more than I thought it was. I ended up loving it. My first year was really, really rough. But once I got past that year mark and I felt confident, ICU nursing was so rewarding. It really completely just changed my outlook on so much in life. I feel like it really matured me and gave me a lot of experiences that I will never forget. And they're still the foundation of my anesthesia care today. I knew I wanted to go into anesthesia for sure at that point because I absolutely loved critical care. I loved that like intense moment to moment like management of patients, of critically ill patients. And I knew that anesthesia was a lot of that. So I was like, that's it, it sealed the deal. So I applied to school and I got in at the University of Pennsylvania and I got my master's degree there. And I got my my first job right out of school in an academic medical center in the area as well. I don't share where that is online just because I don't want my TikTok or Instagram stuff to be connected with work. We have some pretty strict social media policies, so for that reason I don't say the name, but it's a large academic center in the Philadelphia area. So that's it. All right. Let's talk about really quick what a typical day looks like, and then we'll pause and we'll look at some questions and we'll get into some of the more anesthesia nitty gritty. So a CRNA, like I said, usually we're in the OR the whole time with the patient from beginning to end. So my day often begins the night before. I look up my cases for the day. If I have any patients with a complex medical history, I'll do a little bit of research on that. There are thousands of comorbidities and diseases and drugs patients could be on. And the routine stuff, you know, you eventually just kind of know like the back of your hand, but every now and then something weird pops up, especially in a large academic center. You get patients from around the country with incredibly rare diseases. So sometimes I have to do a little research on those, or it's a new case that's kind of experimental. I've never done anesthesia for that kind of surgery before. So sometimes I have to do a little bit of research. I usually get to the OR. I show up at work around 6:40 in the morning. That's when I have to clock in. And I take about 20 minutes to set up the operating room. We check our anesthesia machine, which is a ventilator, and it also delivers anesthesia gases to the patient and has a monitor on it. So we have to check that to make sure it's safe for operation. I set up all my drugs. I set up my airway equipment. And then I will talk to the patient, the surgeon, and the anesthesiologist and make sure we're all on the same page about a plan. The nice thing about my job, and I think most people, is that it's really collaborative. So you know, I don't just like show up to work and have someone tell me what to do. I show up and I have a really nice team discussion and I say, you know, what do you think is best for this patient? I'm thinking we should probably intubate. Do you think the patient needs an arterial line? Okay, how about we use this kind of pain management? You know, it's kind of like a back and forth. So we come up with a plan together, the three of us, and take the patient in the operating room, proceed with the procedure, manage their airway. And I know that sounds like a vague term, but you know, either put in a breathing tube or an LMA, or if we're going to keep them breathing on their own, we'll move forward from there. Get them on the monitors. We monitor them throughout the procedure. Watch their vital signs. We give them fluid. We give them blood if they need it. We give them pain medicine, nausea medicine. If the blood pressure is too high, we bring it down. If it's too low, we bring it up. We are monitoring their position, making sure they don't get nerve injuries. We are monitoring urine output, blood loss. Gosh, there's so much. So, you know, at the end of the case, we wake the patient up or bring them to the ICU, whichever one, and start again. So I work 13-hour days. I do 3 13-hour days a week. So I typically do like anywhere from 3 to 5 cases a day, depending on how long they are. You know, you might get a spine surgery that lasts 12 hours, or you might get 15 endoscopies and they're 30-minute cases each. So it totally depends on the day. Every single day is different. Sometimes I'm in the electrophysiology lab. Usually I'm in the main OR doing a lot of cancer surgeries, a lot of like general surgeries, so stuff in the abdomen, a lot of, sometimes we do thoracic surgery every now and then, like cutting out little pieces of the lung. I don't do it that often. A lot of ENT, head and neck cancers. Gosh, anything. It could be anything. So that's a typical day. It's always a surprise. Sometimes in the morning you might start out in one kind of surgery, and then the afternoon you'll get like a hip replacement, and then you move to another room and you do a spine, and then at nighttime you do a trauma. It's just different every day. All right, so I'm gonna hit stop share for a second and let's go to the chat. So many good questions. Oh my gosh. Okay, well, let me scroll down. I see where a lot of people said their name and where they're from. Okay. Okay, here is the first question from Rico. Okay, Rico attended the virtual shadow on 9/23. Oh, nice. You said, say a patient is scheduled for surgery. They were cleared by cardiology. Have I ever canceled a surgery from an anesthesia standpoint? Yes, absolutely. So that is a huge part of our pre-op assessment, is making sure that the patient is safe to undergo anesthesia. Anesthesia puts stress on the heart, about the same amount of stress as it would take us to walk like 2 blocks, go up a flight of stairs. So we ask patients, like, when you're doing that, you have to stop and catch your breath. So we also have all of their, especially if they're older and it's a big surgery, you want to look at their EKG, see if they have an echo, if they have a stress test. You want to see what they have plans. Sometimes they don't appropriate for surgery. So, you know, I've definitely seen cardiac clearances that were a little sketchy. Not so much recently, but during my training, a cardiologist just says that it didn't seem appropriate. So I was a student at the time, but my CRNA and anesthesiologist ended up getting. Sometimes we delay surgeries for if a patient ate that morning, like they had a piece of bread on the way in, like we can't move forward if you have food in your stomach. That's a common reason for canceling or delaying a surgery. I'm trying to think of any other reason why we would cancel. So many of our patients at the current hospital I'm working are urgent, so there's not a lot of times when we will cancel. If you are doing outpatient elective anesthesia, like in a surgery, so some surgery center is like way over the safety limit that's supposed to get caught beforehand. They have a BMI maximum of 45, so really severe patients should not be done in a surgery center because they are at higher risk to have failure of the airway or to have you know, a heart attack during surgery or something like that. We really need to show appropriate resources for those patients. So we have canceled patients for being too large for the surgery center, the building that we're in, since it's not attached to like a main hospital that can appropriately treat them. So those are probably the main things. Maybe out of control blood sugars, that's another one. So diabetic patient who and the blood sugar is like 400 in the surgery center, which they're to the main hospital to get like an insulin infusion. Okay, you want to be a CRNA in the Army system? Do you know about this? Yes, I do. So CRNAs in the Army, it's a cool job. So they are the frontline anesthesia providers. You could be working anywhere from like just military hospitals and cities to MASH units to, you know, rescue crews, literally going to keeping people alive. It's really crazy. Typically, CRNAs are in the initial surgical bay. Typically, you're not like running into like war necessarily, but there are like search and rescue teams that will have CRNAs on them. So, and they also pay off your student debt. So that's a really great way to do it away if you're interested in that. For me, I don't want to do anything that intense. I already do trauma, and that is enough action for me. So it's awesome. It's awesome that you can do that. The difference between a CRNA and a physician anesthesiologist, ask Anna. So it's really all in the training in the background. Physician anesthesiologists go to medical school. They do a residency in anesthesia. The anesthesia residency is a 1-year internship where they just do like general medicine, and then they do 3 years of anesthesia residency. Physician anesthesiologists, it's becoming less and less common to see them doing direct anesthesia care, direct providing. Although they still can do it. There are places that do, but it's not very common on the East Coast or in the South, just so you know. So usually the physicians are supervising. The physicians, what I will say, the one huge benefit I see to going that route is go on and do a fellowship in critical care, regional anesthesia. You could go on to do like a fellowship in cardiac. Even though CRNAs can do cardiac, there's like special cardiac fellowships for physicians. So you get really good at doing like echoes and TEs, and you're more likely to do like big cardiac cases in academic centers. Maybe in a team with either a resident or a CRNA, usually newly alone, but just, you know, that's like the one benefit to the physician route. Okay, I'm just gonna take a few more and we'll get into the case studies. I am kind of lost when I graduate. Someone asked what the best specialty to be in when you graduate your BSN. You have to have critical care experience, so you need to get into an ICU. And I'll answer the AA question, and then we'll go back into the case studies. So Maria asked about anesthesiology assistants. So the anesthesiology assistants are like PAs. So they have their own program. They do a 4-year bachelor degree in whatever and have to take all the pre-med courses. And then you can go straight into an AA program, and it's 2 years. So it's a master's degree. The only thing that's like, so in an anesthesia care team model where you're working with a physician anesthesiologist, the CRNA and the AA would have like the same role, the same job. AAs can never be independent though. So like CRNAs are often working independently in rural areas and small facilities like dental office, fertility clinics. They're independent in the military. AAs can't do that right now because as CRNAs, we practice legally under our nursing license, and we get an advanced practice nursing license. So that allows us to like prescribe and diagnose and do all those things. AAs have to practice under the physician's license. So that's why they can't be independent. AAs also only exist in 18 states. So as of right now, that's like a big limitation. If you want to move to the East Coast, they're not up here. Like they're all mostly down south right now. So that is like the one drawback and why I don't currently recommend that route. But if you live in an area that has AAs, then I think it's a really good option. Like if you were in Georgia, for example, like Atlanta, Georgia, there's tons of AAs in Atlanta, Georgia. So if you want to live in Atlanta, it's a good option. I'm going to go back to screen sharing, and we are going to continue with a case study. Otherwise, I can talk for days. Okay. So let's talk about, so we'll see how the time goes. I have 3 case studies up here. I'll start with this one because it was really interesting. This is a true case study that happened to me my 2nd week ever as a nurse anesthetist. I was working in the surgery center, which is across from the main hospital. And it was a carpal tunnel repair. So a really, really easy surgery, right? It's just a surgery on the wrist. It's typically MAC anesthesia. That's monitored anesthesia care, also known as twilight. The patient's breathing on their own. You just get them sleepy. They're just taking a nap like La La Land. And the surgeon uses lots of local anesthesia to numb up the area and does the procedure. You turn off the drugs, the patient wakes up 5 minutes later. It's amazing. So, but the case got a little interesting, so here we go. So our patient was a 62-year-old female, here for a left carpal tunnel repair. No known drug allergies. She was a smoker for 20 years, a pack per day, but she no longer smokes. She does have acid reflux, but it's controlled well with over-the-counter medications. For anesthesia, those could be red flags, but in her case, it ended up, you know, this is the thing, after somebody quits smoking, every year that they have quit, their body starts to recover. So the fact that she hasn't smoked in over 20 years, says to us that she's fine. She shouldn't have any reactive airway disease. She didn't appear to have any like long-term pulmonary complications from it. Her heart should have recovered by now. So, I mean, you can still have like some permanent coronary artery disease from it, but she was young when it happened and it was a long time ago. So we're not worried about her airway from a smoking standpoint. And acid reflux can cause aspiration and can cause acid to come up into your airway when you're asleep with an unprotected airway. But if it's well controlled with Pepsid or, you know, like a PPI, a proton pump inhibitor, or any over-the-counter medications, then we typically don't worry about it. She had surgery before when she was young. It went fine. No anesthesia complications that she knew of. We don't do an EKG or labs for patients like her because it's a minor procedure. The anesthesia is low risk, and she was very healthy, so she's low risk. So we didn't need any of that. And she didn't eat anything since last night, the night before. So she was very low risk for aspiration. So she's like a perfect candidate for MAC anesthesia. She also had she's also quite thin. So that makes keeping her breathing on her own a little bit easier because there's no extra soft tissue in the airway. So she's kind of like a perfect MAC candidate. So when we did her airway assessment, we did notice a few things that we didn't like so much. She had a short thyromental distance. So your thyromental distance, see if you can see me. This is technically called your mentum. And then here's your thyroid cartilage. So the space from here to here, we want to be at least 6 centimeters long, or 3 finger breadths. And that shows us about the amount of room that your submandibular space can hold your tongue. So when we go to intubate a patient, when we go to put a breathing tube in their airway, we need to mash the tongue down to this submandibular space. So if it's really, really narrow, if the patient doesn't have a very long thyromental distance, there's not as much room to displace the tongue. That can make it harder to intubate them. It can make it harder to get a view. So hers was very short, which made us think she might be harder to get a breathing tube in. But again, not to worry, because she's going to be breathing on her own. Small mouth opening as well. That also makes it challenging to intubate a patient. But otherwise, her physical exam was fine. Lungs cleared auscultation. Her heartbeat was regular. No issues. So again, anesthesia plan, MAC, natural airway, either a nasal cannula or a non-rebreather face mask. I usually do just the non-rebreather because it's easier to read the carbon dioxide reading that shows us how well the air is exchanging. So if a patient starts to obstruct, starts to close off their airway for any reason, besides looking at them directly and seeing it, you can look at the waveform on the monitors. It's a really early indication of airway obstruction. So the non-rebreathers tend to make it very easy to read the carbon dioxide, the end-tidal carbon dioxide. So I decided to do a propofol infusion for her. And this is like a typical way that I would normally do this. I usually start the drip a little bit higher to get them nice and deep, because injecting the local is pretty painful. And then once that area is numb, they shouldn't feel anything. And then once she's good and numb, we can back it off and lighten up the infusion. Gave her a little bit of fentanyl up front, 50 micrograms. Some lidocaine, we give that before the propofol. That numbs up your veins. It also helps decrease coughing. It also, 60 milligrams of lidocaine went to this, but higher doses of lidocaine can also have some pain relief effects. And I gave her a little propofol bolus before the local anesthesia. 40 milligrams is about 0.5 milligram per kilogram. I think she was actually only like 65 kilograms, so it was a little bit more than her 0.5 milligram per kilogram dose, but essentially that's just to get her, like I said, a little bit deep before the local. So here's where our very boring, very easy case got exciting. Not in a good way. She had a laryngospasm. So I'm going to play this video. I hope that it becomes clear. And this is going to show you what a laryngospasm is. We can talk about it. There we go. It's starting to clear up. So this is the airway. See those doors flapping open and shut? Those are the vocal cords. And so the vocal cords are the gateway to the trachea. That's where air exchanges in and out. That's how we talk and phonate. That's what we breathe through. And when the vocal cords shut like this in a spasm, no air can pass. So that is very, very bad. We don't like that. You will desaturate very quickly, and your body will still try to breathe against those closed doors. So what happens is, especially with young, strong men, if you try to breathe and take in all that negative pressure, use all your muscles, try to get air in against the closed doors, you can actually cause negative pressure pulmonary edema. So you can actually essentially get like swelling in your lungs. You will get like fluids filling your lungs because of all of that negative pressure against the closed doors. Essentially causes that response. I don't know, it would take a really long time to explain it. I could give a whole lecture on it, but that's my three-word explanation. And this is the epiglottis, that like round thing you see on top. So when we intubate, we put the tip of the blade above the epiglottis, where the epiglottis and the tongue meet, and then the tube should go through the vocal cords. Okay, so she has a laryngospasm. Not good. So as a new CRNA, I had been trained in this. I actually found this very nice flow sheet diagram online. I had never seen a laryngospasm algorithm before, but this is essentially what you're supposed to do. So the patient didn't fully laryngospasm right away. She had a partial laryngospasm. And laryngospasms essentially happen when you're in a lighter plane of anesthesia, meaning you're kind of like in that light twilight, and then something really painful happens, or maybe some secretions drop onto your vocal cords and tickle them. So that's essentially what happened. The lidocaine was very stimulating for her. When the surgeon started injecting it, she still wasn't deep enough. You know, we do our best to predict what patients need, but it's never 100% certain. And then she did have like some secretions back there, like some drool that like started to get onto her airway. So she started kind of coughing and sputtering. And that's how I knew she was starting to have a partial laryngospasm, meaning the vocal cords were probably opening and shutting like this. So she's coughing, she's bucking. The first thing I did was try to do a little jaw thrust, chin lift like this. That usually can break it, especially if you catch it early, which I did. I tried to suction the back of her throat to get the noxious stimuli away, not the noxious stimuli, the secretions out. And the surgeon stopped injecting the local. So I told him to stop injecting. So take away the noxious stimuli, take away the secretions in the back of the throat. Unfortunately, she had already started clenching her teeth. So I couldn't get the suction cannula in. And that continued to make her laryngospasm. So even though the surgeon stopped what he was doing and I gave her the jaw thrust, because the saliva was still right above her vocal cords, that unfortunately made her keep coughing and sputtering. And she progressed from a partial laryngospasm to a full laryngospasm. So at this point, her oxygen saturations were still okay, but I had to call for help. So I needed to give her some more propofol to get her deeper, which I did. I gave her a little bolus of propofol. And I started to ventilate her. The next step would be to give positive pressure ventilation. You get a nice seal with your mask, your anesthesia mask, and you give some positive pressure, and that should pop open the vocal cords. That would be like the next step in what you should do. Unfortunately, it was really hard to get a good seal on her face because her face was so tiny. And because we were doing a carpal tunnel repair, her head was not near the anesthesia machine. The bed was turned 90 degrees. So her head was all the way here and my anesthesia machine was all the way over there. So I could get the mask to her, but I couldn't squeeze the bag and hold the mask down at the same time. So the surgical resident ran around the side. I tried to explain to her how to close the pop-off valve and squeeze the bag, but she didn't really know how to do that. She'd never trained in anesthesia. It's a little bit different than an ambu bag, what most people are used to. So I asked the nurse to please call overhead for help. And my friend Amanda came in the room. And my friend Amanda was also a new CRNA. We went to school together. So Amanda, helped me squeeze the bag, try to give positive pressure. We kept trying to call my anesthesiologist and he wasn't answering the phone. He wasn't getting Wi-Fi. We tried to call overhead for the anesthesiologist. Nobody heard the overhead pages for some reason. And this just kept happening. Like she would stop spasming for a second and then it would just start again. So eventually her oxygen saturations started to drop. And that's when I got really scared. Like, oh my gosh, like I have 2 anesthesia providers in here. It's still not breaking. It keeps happening. What do we do? So we ended up pulling the code bell to get people in the room. So everybody came in, all the nurses from the recovery area, the charge nurse, both anesthesiologists that were there that day came in, and we ended up having to go further in the algorithm to succinylcholine. So we gave her a short-acting muscle relaxant. It's a paralytic that relaxes the vocal cords open in that situation. We turned off all the sedation. We were planning to just like wake her up and start from scratch. And so we gave the sucks, we woke her up. She was totally fine. Her oxygen saturation came right back up, no big deal. When we tried to resedate her, she laryngospasmed again. This time with my anesthesiologist right next to me. So he believed me. That was proof that she had a very reactive airway, is what we like to call it. And we ended up making the decision to go ahead and just convert to general anesthesia for the case so we could protect her airway, because spasming over and over is not a safe situation for the patient. All right, so let's see if I can. All right, so here's quick images of the steps that we had to take. So that picture with the hands on the man's jaw, that's the laryngospasm notch, we call it. You push in and kind of give a jaw thrust at the same time, and that's very stimulating and should get the vocal cords open. I tried to suction her with our yank hour. That's the picture in the top left corner. Couldn't get her mouth open. The bottom left corner, that's an anesthesia mask. That is what I tried to get a seal over her face with to deliver positive pressure ventilation. That didn't do it. Propofol up top didn't do it. And then finally the sucks worked, but again, as soon as we put it right back to sleep, we were back to square one. So my anesthesiologist, so the bed was still, 90 degrees at this point. We ended up turning it so that it would be closer to the anesthesia machine again. And he decided to just intubate her. He just said, oh, just grab the breathing tube. Like, I'm just going to intubate her. Either of us could have done it, but he decided to just go for it. And of course, this is what we want it to look like. When you do a direct laryngoscopy, that is a cartoon of the vocal cords and where we want to put the breathing tube through, and that is how it should look. You take I think I used the Mac 3 blade. You take our little blade, you put it in the mouth, you sweep the tongue to the side, and you lift up, and right through the vocal cords is where you should be able to go. But remember, I said in the beginning of the case study, she had a small mouth opening and a short thyromental distance. So unfortunately, all we could get was a grade 3 view. So these are the different grades of how we describe what our view looks like when we go in the airway. The top left corner is a grade 1 view. That's ideally what it should look like. That makes it really easy to put the tube through. You just go right in. Grade 2 view, you can see part of the vocal cords and the larynx. A grade 3 view, all you see is the epiglottis. You can't see the larynx at all. And a grade 4 view, you can't see anything. All you see is the hard palate and the soft palate. So we had a grade 3 view, unfortunately. So that's because she had like I said, the short thyromental distance. So that was very frustrating. Let's see if I can move this chat box. Okay. So over on the right-hand side is a picture of a bougie. That is an airway device that we use in cases of grade 2 or grade 3 views. Not usually a grade 2, but in a grade 3 view, ideally, it's like a little, it's called a gum elastic bougie. It's like a soft, flexible plastic, and that little curved tip is what you put, hopefully, through the vocal cords, and you can feel the vibrations of the tracheal rings as you advance. It'll go bump, 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 and that tells you you're in the trachea. If it goes in smooth, it means you're in the esophagus. So I grabbed the bougie, I handed it to him, and he blindly put it in, and thank God, got in the trachea, and we were able to slip the endotracheal tube over it, and I cried. We were able to get her intubated. So that was my reaction afterwards. I was very upset about this. It was only my second week as a CRNA. I thought it was a total failure for not being able to handle this, but when I look back at this 3 years later with more maturity, I realized I actually followed the algorithm perfectly and did everything I should have. But sometimes, and I still give anesthesia for carpal tunnels like that all the time, that formula is still a great formula. It still works. That patient just happened to have a very reactive airway. So our job as anesthesia providers is to expect the unexpected and be prepared to move down the algorithm and treat problems as they arise. So it worked out. She did great. She woke up at the end of the case. She was very happy, never knew the difference. So the moral of the story is you're not a failure just because an unexpected outcome happens. So I'm going to stop the share quick and take a look at the time. It's 4:42. That I'm going to answer some questions and we'll do like a really, really quick mini case study. I don't want to do another full one because I think that'll put us over time probably. And I want to be able to get to all your questions. My goodness, there are just so many. Okay. Okay, so Jennifer asked, what encouraged me to become a CRNA over attending medical school? And if I could go back, would I pick a different career? You know, it's funny, Jennifer, my parents, like I said, were very discouraging of me going to medical school, as was like a lot of my family, which is funny because I think for most students, it's the opposite. I think that I was like letting people talk me out of my original dream. And if I could be like 18 all over again, I truthfully would probably just tell myself to go to medical school, honestly. There's other specialties I was equally interested in as anesthesia, and I think would have made me equally as happy. Like I love OB, for example. There's just like a lot of things that I'm interested in. And at the same time though, I still really love being a CRNA, and I think I'm equally happy this way. So it's really hard to say. The good news about being a CRNA is it is a little bit less schooling. You can start your career sooner, hopefully with less student debt. I was able to become a CRNA by the age of 27. So I think that like is a really rewarding thing to be, and also during your nursing years, you get a lot of cool experience and you're able to travel and make money. So even though like maybe my final career destination occurred by age 27, I still had a lot of years out of school getting to like live my life as a young adult that I really wouldn't trade for the world. I had a lot of really amazing experiences. So if I could go back, I would have, if I were to talk to 18-year-old me, I would tell myself like, don't listen to those people. Like medical school is totally fine and it's a totally valid option and you can do it. But I'm still really happy with where I ended up. Like I still would recommend CRNA to people every single day of the week. I still love this career. So I think either one is great. That's a really hard question. I don't know. I hope that answered it. With what you're talking about right now, is this in the ER department? No, this is all in the operating room. How does the DNP affect current CRNAs? We are not required to go back for our DNP. We are grandfathered in. I will still probably get a doctorate of some sort. I'm not sure if I'll do my PhD or my DNP. You can also get a PhD. To be determined. That's just because I'll probably teach one day. And this is my favorite question from Dana. I answer this question every day, and I'm going to tattoo it on my forehead, Dana. How can you prepare yourself to become an ICU nurse? You should get a nurse externship or a CNA job. That is the absolute best preparation you can do, especially if it's in an ICU, ideally. All right, let's go back to screen sharing, and we're gonna, actually, let's not do this one. Okay. Sorry, I didn't mean to minimize this. Mini case study about an anesthesia case gone right and how anesthesia could also look. So let us share the screen again. So anesthesia is not all stress and terror. Sometimes it is happy and it is creativity and it is beautiful. So this was an ovarian cyst removal for a young 26 years old, no known drug allergies, no past medical history at all, except for the ovarian cyst that she had. This was elective. A lot of times ovarian cyst removals are emergent because it's causing twisting or torsion of the ovary, and the patient could actually lose the ovary due to necrosis and lack of blood flow. But this was just an ovarian cyst that was very large and threatening to do that, so they were taking it out before it became a problem. She had an excellent airway, Malampati 1, meaning you could see everything when she opened her mouth and stuck out her tongue. You could see the whole back of her throat, including the uvula. She had a thyromental distance of greater than 6 centimeters. Her lungs were clear. She did have a history of post-op nausea vomiting that I thought I put in the PowerPoint, but I think I messed that up. I apologize. So she has gotten nauseous in the past with anesthesia. So that is like where the creativity came in. Like, how do I get this young girl through surgery so that her pain is treated without getting nauseous? She's a really high-risk female. It's a laparoscopic surgery, so in the abdomen. That puts you at high risk for nausea. Gynecologic surgeries put you at a higher risk for nausea. And she had a history of nausea, so she checked every single risk factor for nausea. She's pretty much 100% guaranteed to puke after surgery, which is terrible. Nobody wants that. It's worse than pain for most patients, and it also puts you in more pain because you're putting stress on the abdomen. So what we decided to do was general anesthesia with an endotracheal tube. We always do that for laparoscopic procedures because they're blowing lots and lots of carbon dioxide into the belly so that they can see with little cameras. And that puts you at risk for aspiration. So in order to keep the patient very still and so that the CO2 doesn't make you vomit, you have to use an endotracheal tube. And we did total IV anesthesia, which is a great way to help decrease nausea risk. Running a propofol infusion helps prevent nausea. It has some antiemetic properties, propofol itself. And our anesthesia gases also put patients at high risk for nausea. So avoiding the anesthesia gas and also using a primary anesthetic agent that prevents nausea both significantly decrease the risk of nausea. It's my favorite technique for people at risk for nausea. I also gave her a scopolamine patch. It's a little sticker that goes behind the ear. Scopolamine is an anticholinergic drug. What's interesting about that is you can use it on cruise ships if you get motion sick. You can get it from your doctor, normally at home. Scopolamine also, the patch can stay on for up to 3 days. So if you have to take opioids after surgery and those make you nauseous, you can keep that on at home. So
I know any of this stuff. So.
What's up? I don't know, maybe someone's mic is on. Okay, sorry. So yeah, the scopolamine will help prevent the nausea with taking the opioids as well. And it's really effective if you give it before surgery. I gave her 2 milligrams of midazolam for anxiety. That also can help with nausea, believe it or not, just decreasing the patient's anxiety alone. We give dexamethasone, which is a steroid that helps reduce the risk of nausea. Primary propofol infusion. We ran a remifentanil infusion, which is a short-acting opioid that is very potent. It's more potent than fentanyl, and it lasts for only 8 minutes after you turn it off. You have plasma esterases that chew up the remifentanil in your bloodstream so that it doesn't last, it goes away. She had 100 micrograms of fentanyl for induction of anesthesia, meaning putting her to sleep, 200 milligrams of propofol. During the case, she just got another 0.5 milligrams of Dilaudid, just because of the laparoscopic sites can be a little painful. 15 milligrams of Toradol or Ketorolac, that is like an IV ibuprofen kind of thing, and Ondansetron or Zofran for nausea at the end, 4 milligrams. And the result was this young lady had a perfect anesthetic with no nausea and no pain when she recovered, and she went home feeling great. So anesthesia doesn't always have to be doom and gloom. It doesn't always have to be emergencies with the airway. Sometimes it's just simply coming up with a painted plan that can help your patient feel less anxious, more comfortable, and have a good surgical experience. So that was, it sounds and basic, but to me, that's a huge victory, because having surgery is one of the most vulnerable times of your life. And if you can come out the other end and have a good experience, that is one less trauma for a person to go through. So let's go back to the chat. Nice. Okay, I'm glad I didn't do the other big case study because we would have been way over time. Okay, I'm gonna work from the bottom up. What courses or resources, do you recommend for current nursing students who are interested in the field of anesthesiology? So I really would recommend, rather than taking extra courses, just focusing a lot on your chemistry classes and your anatomy, physiology, and pharmacology classes. Really mastering those are super important. You know, some nursing schools, unfortunately, I think this is a big drawback to certain programs. They have chemistry for anesthesia, chemistry for nursing, biology for nursing. I think that those classes sometimes get watered down, and that's unfortunate because, you know, if you go into NP school or CRNA school, or, you know, even just work in like critical care, like having a really good foundation in those subjects is important. So I prefer nursing programs that let you take the regular course with other students. Like my chemistry courses and biology courses were just generic ones with like students from all degrees. And I think that that really helped me master chemistry a lot better than taking like a watered down version. And Rico said organic chemistry, and you're right, Rico, thank you for adding that. I forgot that that's not in most nursing programs because mine was a second degree. So yes, organic chemistry is like the one that's definitely super beneficial to take, because it definitely comes into anesthesia a lot. But, you know, more so than the extra courses, I would really focus on getting a nurse externship or CRNA. I know it sounds really basic, but it will prepare you to be a nurse a lot better than nursing school does. It will help you get more out of your experience at clinicals. It will give you great connections. It will help you get into an ICU sooner. And the sooner that you become comfortable as a nurse and the less you're focused on just learning basic tasks, the quicker you can jump to the big picture, critical thinking, and like doing more like cerebral work as a nurse. So instead of just learning the tasks, you'll have already mastered that by the time you start your first nursing job. And then you can focus more on putting it all together and synthesizing the information. Okay, so someone asked, Tazia, anesthesiologists have insurance costs. Is it the same for CRNA? Yeah, so we have to have malpractice insurance also. We are both legally liable for the patient. Even if you're in a care team model, you can both get sued. You're not just like working under their malpractice insurance, you work under your own. So usually if you work for a hospital, it's part of your benefits package. The hospital covers your malpractice insurance. That's like pretty standard. If you like work on your own as like a locum CRNA and do 1099 work, meaning like you can contract yourself out to hospitals individually, like, hey, I'll do, you know, this assignment for however many months, then you should buy your own malpractice insurance. But usually if you work for a group or a hospital, it's covered for you. And everybody, okay, so Serby L asks, the TIVA, what does TIVA mean? It's total IV anesthesia. Thank you guys for answering that. That's correct. Do anesthesiology doctors have authority over CRNA? This is such a good question. So the answer is yes and no. So because we work as a team, both of our names are on the chart and we're both liable for the patient. The anesthesiologist on the case is not necessarily like your boss. You kind of have to both agree. So let's say, okay. So in real life, 99.99999% of the time, we're both in agreement and we both like want to do the same thing anyway. Every now and then we'll have like slight differences of opinion of like, oh, like I think this patient would really benefit from ketamine. Oh, I don't really like ketamine. Like, would you mind not doing that? Okay, sure. You know, we might like talk about things like that. Oh, can you order Tylenol pre-op? Sure, no problem. Like it's a lot of like back and forth like that collaboration. If you work with a physician who you feel wants to do something unsafe for the patient, something you really truly disagree with, like big time, you absolutely do not have to do that. And in fact, I did work with an anesthesiologist who I felt was unsafe at one point in my career, and I did often refuse to do the things that he asked me to do because I just thought they were completely absurd. And it got to the point where I ended up reporting him to the administration because it was so, I thought it was just so egregious, and the administration completely backed me up and completely agreed with me. So you do not like have to do what they say just because they're a doctor. You are still responsible for the patient, so you still have to do what's right. So really it's collaborative. We agree as a team and we work together. If I'm working with an anesthesiologist and they feel really strongly about something and I feel like it's safe, I'm happy to do it. Like, you know, if they just love ketamine and they just really want to use ketamine and I don't care either way for the patient, I think the patient could go either way. But yeah, sure, let's do ketamine. As long as it's safe and reasonable. But nobody can ever force you to do something that you feel is unsafe. What advice for a high school student who's interested in the medical field? My best advice would be to get out and shadow, but that's really hard right now with COVID. So my next best advice would be continue to attend these things where you can see different options and start to get an idea of what you're interested in. The good news is you have lots of time in college to figure it out. If you pick, you know, a major that you're interested in and just start taking your science courses that will allow you to enter a health profession, that's great. My cousin did that. My cousin Lydia, she just graduated college. She just started in, I think her school called it like a health sciences major. But essentially she just like took all the pre-med courses and she tried out a bunch of different internships and volunteering, and she decided to become a physical therapist. So she's interviewing for physical therapy schools right now, and it's perfect for her. So along the way, definitely get part-time jobs in different things that you're interested in. Like she tried out being a nurse's aide. She tried out being a PT aide. She did a lot of different things, and that's how she discovered it. Being a nurse's aide is what introduced me to anesthesia. Had I not had that experience, like if I had become an EMT, maybe I would have gone to PA school, or maybe I would have gone to med school. So really like these experiences open doors and lead you down different pathways that you wouldn't have gone down otherwise. So try lots of different things. And if you're in high school, you can become an EMT. I think once you're 16 in most states. If you're younger than 16, you could do EMT junior, or maybe it's 18 for an EMT, and maybe 16 and up is EMT junior. But like you could do a junior EMT program through your fire department and like, you know, experience healthcare that way. 16 years old and starting 1-year LPN program. Do I have any tips? Wow, I didn't know you could do that at 16. That's pretty cool. You know what? It's okay. Nobody else is going to know anything in your program either. they're going to teach you everything you need to know. So be kind to yourself is my advice, and just take it one day at a time and just ask lots of questions. Rico is clearly an anesthesia guru over here. Rico is asking, when do you use a glide scope rather than a blind intubation? Glide scope is always preferred over blind intubation. You know, in our case study with the young lady who we had to convert to general anesthesia with the carpal tunnel repair, the glide scope was not in the room and the bougie was right behind us. So we grabbed the bougie first, and at the same time had someone on the phone calling our anesthesia tech, asking them to please bring a glide scope. So, you know, if the bougie didn't work, the glide scope would have gotten there seconds later. So glide scopes, I think, are great to have in the room. Anytime you think a patient might be difficult, just bring it in the room. We're getting short on time, so I just want to like make sure I get through these questions quick. I am currently doing, Kelly says, I'm currently doing a research project about death in medicine. How patient deaths affect those in the medical field. Do you find patient deaths affect those at CRNA? And many medical schools don't offer programs to prepare students for potential deaths. Wow, that's actually that's a really important thing to talk about. So thank you for asking that question, Kelly. So thankfully in anesthesia, we don't see nearly as much death as I did in the ICU. Working in the ICU is very tough. You will see a lot of people die, and you will become very close with them before they die, and the losses affect you greatly. They're very upsetting. One of my first patients in the ICU, we took care of him for months and months and months. All the new grads did, because he was kind of like stable. So he was like a good patient assignment for newer nurses. And after months and months and months of taking care of him and getting close to his family, he died, and we went to his funeral, me and all my new grad cohort. And it was really touching, and we became very close with the family. I cried when he died, and I still remember him. You get better at it. You get used to death. You learn that just because you can't save them doesn't mean you did anything wrong. Just like how the same lesson with the laryngospasm, like just because there's a outcome that you don't expect doesn't mean you did anything wrong. In anesthesia, usually people don't die in the OR. It does happen sometimes. Sometimes we do anesthesia for organ donations also, and they don't usually affect me that much, but sometimes some of the traumas can be very upsetting, because oftentimes they're young patients who are healthy otherwise, and you know, they kind of feel like unfair, tragic deaths. And I did have like a very traumatic experience a few months ago with a trauma patient who was doing, it was an organ donation. So I was not prepared for it. It really emotionally was very draining. And I came home and I cried to my husband, and I had nightmares for 2 weeks. So, you know, PTSD and all that burnout is very real in the health field. I think the best thing you can do is get people you trust to talk to about it. Go seek therapy early if you need it. There are books on the subject. Atul Gawande has a really good book called Being Mortal. So I recommend everybody read that book who is interested in going into healthcare, because it helps you cope with death a lot better. It helps you understand that death is natural and normal, and keeping that perspective. We have a society that doesn't really talk about death much, so keeping a healthy perspective of death helps it be a lot less traumatic. Okay, so before I answer any more questions, am I okay to ask a few more, guys? Answer a few more, because I don't want to run over time too much.
Yeah, no, you're good. You can answer as many as you would like.
Okay. I didn't know if it was like a strict time limit.
No, you're good, yeah.
So Morgan asked if I ever passed out during a procedure. No, I have not. But when I was shadowing anesthesia for the first time in Mexico, and I saw my first C-section, it was an emergency C-section, and those are freaking brutal to watch. Nobody warned me. I did not eat enough breakfast that morning, and I almost passed out. All of a sudden, I saw brown, and I told my preceptor, I was like, I have to step out. So I stepped out of the room, and I sat on the floor, and they gave me some orange juice, and I was fine. The advice is, as soon as you start to feel off, just sit down, please, wherever you are. Medical schools pass out, medical students pass out in the OR all the time. Nursing students pass out in the OR all the time. Not all the time, but at least once or twice a year it happens. We've all seen it before. I had a dad pass out on me in the OR once in OB when I was doing anesthesia for a C-section. The dad gave me the baby. Like the baby was out and the dad happened to look over the drapes and he said, I'm going to pass out. You have to take the baby. He handed me the baby and then he hit the floors. Please sit down and eat your breakfast. Anyway, so you were volunteering, you saw a chest physician. Oh gosh, you locked your knees. No, you're right. You always have to eat breakfast and don't lock your knees. It still gives you anxiety about surgery in the ICU. It's fine. You know what? You will get over it. The more you see it, the less things like that will disturb you. I've seen a million C-sections since then, and I have not passed out since. The other day, though, I was in the OR, and I saw them do this crazy cancer surgery where the patient had cancer all up in the neck, and they literally peeled back all the tissues of the neck and part of the face, and seeing the face peel back made me so dizzy and nauseous. I thought I was going to pass out, and I see brutal stuff all the time. I see the nastiest stuff. I've seen limbs get reattached. I've seen arms like just dangling off. Like I've seen the craziest things, and for some reason the idea of a face being peeled off just made me want to vomit. So you'll be fine, but you know, just know your body's cues. Tiffany is starting her first day as a critical care nurse tomorrow. So cool. First year of the ICU is tough. Just keep asking a lot of questions and you will run into some tough personalities. Ignore them. They are just bitter, lame people. Don't worry about them at all. Look for the mentors. Look for the good people. They are everywhere. Every ICU has them. Every ICU will have amazing experienced nurses who will guide you if you just ask. You will have lots of other new grad friends who will share those same anxieties as you. So, you know, befriend them. Just be really, really kind to yourself. Keep studying and keep asking questions. And just know that after about you hit the year mark, you will feel so much better. You just have to take one day at a time. How many years in total did it take for me to start as a nurse anesthesiologist? Also known as nurse anesthetist. Let's keep it politically correct for YouTube. I'll use both words. So I was I became a nurse in 2013. I worked in the ICU for only 19 months before going back to CRNA school, which was very rare. I started applying to schools. All the schools in my area had 2 to 3 year wait lists. And when I applied to Penn, they had a 1 year wait list. It was the shortest one. So I figured I'd be a nurse for at least, I guess that would have been 2.5. It would have been like a little more than 2.5 years of experience before starting the Penn program. And it would have been like almost 5 years of experience if I went to the LaSalle program. So I thought that was like a good range to start applying. And then Penn called me and they had a dropout spot and they asked me to start in like 4 weeks. So I got really lucky there, but also I wish I did have more ICU experience. I think you really do need the full 2 years. I mean, starting out CRNA school a lot harder. I had to work way harder than my classmates did at catching up. So I always recommend you do at least 2 full years. Don't do what I did. Do as I say, not as I do. But that was a 24-month master's program. It's now a 36-month doctorate program. I was the last master's class, which is why I took the opportunity. And I became a CRNA by the age of 27. Okay. Okay, I think I'm caught up on most of the questions. Let's see if there's more down lower. Okay. Do you need past experience to get a nurse externship job? No, absolutely not. Nurse externship jobs are for nursing students and they know you don't have past experience. How is the quality of life as a CRNA? Do you work a lot of hours? Everyone asks me that, which is so funny. No, Ashley, that's such a good question. I'm really glad you brought it up. The quality of life is excellent. So that was like, you know, I think why my family was so discouraging of me going into med school. They really like are quality of life people. Like that's like a value I was taught to value. Being doctors can also have excellent qualities of life. So I, again, think that's a total myth that you can't have a good quality of life as a physician. But as a CRNA, it's excellent. We all work 40 hours a week unless you want to work less or more. But I do 3 long shifts. I do 3 13-hour shifts, and that equals my 40 hours or almost 40 hours. I have to do 1 holiday a year. And when I was working at the trauma center, so I'm in like a academic center that has 2 like main campuses, and one of them has the trauma center and one does not. I, for the last 3 years, was mostly at the trauma center, rotate to the other. couple times a month. We have like 11 different sites we cover, so I go like all over. And I had to do trauma call like maybe every other month, and that'd be like a 24-hour shift on like a Saturday or a Sunday. So let's say like 6 weekend shifts a year and 1 holiday. Like I thought that was pretty good. Now that I'm at the main campus and I'm not in the trauma center anymore, I don't have to do any weekends. We just do Friday night shifts overnight for 13 hours. And that's like 2 of those a year. Like twice a year I do a Friday night overnight. And we take like transplants, like liver transplants and stuff. So it's like kind of a good experience. I actually kind of like that. Right now I'm majoring in business management and you're pre-nursing. Actually, I think that's a really cool thing, Nusrat, because you will have a lot of like a wide variety of experiences. And if you ever want to go into management, that'll be really cool. But you plan to take the pre-requirement program so you could become an RN. That's cool. Nusrat, yes, you actually can absolutely become a CRNA after becoming an RN. You have to be an RN in order to become a CRNA. You're on the exact right track. You must become an RN and you must have critical care experience. So that is part, and that business management experience is cool because a lot of CRNAs contract themselves out to businesses and well, hospitals are businesses, right? They contract themselves out to hospitals and independently practicing surgeons and dentists and fertility clinics and so on, all these places that need anesthesia. So having like a business background, you could start your own anesthesia group with other CRNAs and you can kind of run the business side of it as well as practice. So you can integrate both. There's a lot of CRNA entrepreneurs.
Oh, so I don't have to have a BSN?
Oh, you do have to have a BSN.
Yeah.
Sorry. Yeah. But you can get your BSN online while working as an RN. So you get your associate's degree RN and then you just do your BSN online and that's fine. It's like the BSN courses are not going to give you any more nursing content. It's all kind of like research and like leadership type of content. So you do that online part-time while you're working as a nurse and you don't have to spend any extra time. Just get into an ICU and then just do your BSN. Yeah, do that. So it's a great way. So actually, I'm so glad you brought this up. So guys, if anyone here is in an associate's degree nursing program or thinking about going that route, it's a really great way to keep your student loans down. So associate's degree for 2 years, they're typically cheaper tuition. And again, you can get your hop and then finish your BSN online super cheap. Most hospitals will pay your tuition assistance. Most hospitals pay like anywhere from $6,000 to $8,000 a year tuition assistance or more sometimes, depending on the area you live in. So, you know, those online BSN programs can be really, really cheap. And you just take one class at a time while you're gaining your nursing experience. So you don't lose any time and you save lots and lots of money. And that's totally valid. The only bad news is some places don't hire associate's degree nurses, like big hospitals, especially in cities. Sometimes they want you to have a BSN to get in. But in most suburbs and definitely every rural area, you can often start with the associates and they just make you finish your bachelor's within a certain timeline. Like a lot of patients say like, okay, you can start out like this, but you have to finish in 5 years. So it's perfect. Is phlebotomist a good way to get patient experience? Phlebotomy is cool because it gives you a really great skill that you'll use as a nurse or a doctor. Some doctors do phlebotomy, not that many, but it's still a good experience. And you get to interact with patients, which is like a good people skill. The only thing I don't love about phlebotomy as like your main like pre-med or pre-PA experience or whatever you're using it for, is that you're not going to get a lot of experience like learning about patients' medical conditions and like medications necessarily, unless like you take the time to like look up that stuff. It's just going to be more of that physical skill. So even though that's like helpful and nice and it's a good thing, it won't be as good experience of like helping you really like understand the medical field as like being a nurse's aide would or being even an EMT would. So it's not like my first choice, but it's still a good skill to have. How do I reassure patients who are scared or reluctant to undergo anesthesia? Yeah, that's like a huge people skill you have to have. Essentially, like it's the scariest time of someone's life, right? You're going to be completely vulnerable. You get to research your hospital. You can research your surgeon. You can research the surgery itself, but you don't get to pick your anesthesia provider. You get who you get that day. So, you know, patients are really scared of anesthesia. They're really scared of going under. So proving to a person who doesn't know you that you're going to take great care of them is really hard to do at first. But once you are comfortable, and I think that's why the nursing background is so important. You get really good at talking to patients the more you do it. And you learn how to reassure people, and you learn how to just evoke understanding and empathy, and how to, if you can explain scary concepts in plain language and warn people before you do things, I think it takes people's anxiety down. So I always explain everything. I promise people that there's no surprises. I'll talk them through the whole thing. I ask them if they want to listen to music. I warm up the operating room table before they get on it. So I say, don't worry, it's cold in the room, but the bed's going to be nice and warm for you. I warmed it up. So they know I've thought about the extra details. I say, hey, can I get your warm blanket? I ask them if they have any questions. And then I say, if you come up with any, later, just ask, I'm happy to answer. So just constantly, checking in and talking them through the process, I think really keeps people's anxiety down. They feel like they can trust you. Yes, I do recommend getting the CCRN before applying to CRNA schools. That's your Critical Care Registered Nurse certification. Most CRNA schools require it, and everybody will appreciate it. Okay, there are 42 new messages. What do you guys want me to do about time? I feel
We can, if you're short on time, we can always.
I
don't want to keep you guys forever, but I do want to answer them.
Yeah, we can always also send you a list of the questions.
I'm happy to keep going for a few more minutes. I just want to check in and make sure you guys are good.
That's great. Yeah.
Okay, perfect. So Amira asked, I know you said anesthesiologists more so now look over patients than directly giving anesthesia. You want to be an anesthesiologist more so for cosmetic surgeries. Okay, so Amira, most anesthesiologists and CRNAs, we don't usually just work with only one kind of surgery. You could sometimes stumble into that, but it's pretty rare. So it's very unlikely to become an anesthesiologist or a CRNA and only work with plastic surgery. I guess unless you specifically contract yourself out to a plastic surgeon who has a private clinic, Ricky Brown. If you went and contracted yourself out to Ricky Brown, who has his own little surgery center, then you could totally do that. But most people do all sorts of anesthesia. There are definitely anesthesiologists who direct provide anesthesia. If you're on TikTok or Instagram and you follow Magnolia Prince, on TikTok she's called Balance Anesthesia. On Instagram she uses her real name. She gives direct anesthesia to patients. So it's not that anesthesiologists can't do that, but in large, big hospitals, we're usually working together as a team. In smaller facilities, you can absolutely do private practice anesthesia and directly provide to patients as well. So I would never discourage somebody from going the physician route, especially if you're already on that track. There's no reason to derail. Being an anesthesiologist is still an awesome job. You can still provide direct patient care. So I still think that anesthesiologists are great, and that's an awesome option. If you want to be guaranteed to always be the one in the room giving direct patient care, and you never, ever, ever want to supervise, being a CRNA is probably better. But if you're flexible either way, or you're already halfway to being a doctor, there's no reason to feel like you must derail. Either one, you can totally accomplish that goal. So please don't feel like you have to reshuffle your life for this. If you're not already on that track, I think, or you're already a nurse or you're in high school, it's maybe more worthwhile, not more, it's worth considering both routes. But if you're already halfway to being a doctor, please, you can still do that. I would never tell someone not to. Okay. Do CRNAs put their hands in the patient's organs ever during surgery? No, we don't. Because you would have to scrub into surgery and be sterile. And so we're on the other side of the drapes, managing, the patient's positioning and their vital signs and the medication. So we are not sterile. We are just clean. Yeah, my hands would never really be in the organs that I could think of. what courses should you take to strengthen your GPA before applying? So if you have low science grades, I recommend retaking science courses, anything below a B. So if you got a C in chemistry, I would retake chemistry. If it was just like your nursing classes that don't really have anything to do with like that stuff, like a fluff class, don't worry about it. I would focus more on getting your CCRN and showing like initiative at work. So it's more important to be an expert ICU nurse to get into anesthesia school than it is to have a perfect GPA. So get on a committee, do a research project at work, start an evidence-based practice committee, do a journal club, something like that, where you're like showing that you do research and leadership and that you like to be involved and help your unit become better. And that is going to look a lot better on your applications than just having like a 4.0 GPA. Well, and that's true for anyone, by the way, in healthcare. You know, med schools used to really value perfect scores, perfect MCAT scores, and perfect GPAs. And now they're looking for people to be more well-rounded. So, you know, I'm not saying to not pay attention to your grades or not to study for the MCAT, but what I am saying is it's more important to show that you've had diverse experiences, that you can speak another language, that you volunteer, that you started a Medvocate club, that you, you know, really get involved and are a well-rounded person who really is going to be a good physical therapist, doctor, dentist, you know, nurse, CRNA, nurse practitioner, PA, whatever it may be. They want you to be well-rounded, all of these schools. That's really the theme. And research is a great way to boost your application always. And so is direct patient care. Best way to study content-heavy classes like chemistry or anatomy. My favorite resource is the Khan Academy, KHAN. It's a free resource on YouTube. They also have like tutorials online. The Bill and Melinda Gates Foundation is essentially like sponsors it, and that's why all this information is free. So any concept you don't understand, they almost always have it on the Khan Academy, and they talk through it and they draw it out, and I think it's a great resource. And okay. Sorry, I'm just trying to like go through chat and see if there's anything I didn't answer. I think a lot of these are already answered. Did I feel comfortable working as a CRNA after graduating? Yes, I was so well prepared. I did not feel well prepared to be a nurse, truthfully, but I was very well prepared to be a CRNA. I took a ton of overnight call. CRNA school is very, very clinical heavy. You're spending like at least 40 hours a week in the operating room practicing anesthesia the entire time. So by the time you get out, you've been doing it a long time and you're definitely ready. I think that's it. I think we got all through all of the questions. Except there's one more. Do I recommend to work in any kind of tech in addition to being an RN? No, once you're an RN, like that's the most important experience for sure. So don't worry about that. Just become an excellent expert ICU nurse. That is the absolute most important thing. Do you guys have anything else?
I think that's it. Yeah, thank you so much for taking the time and like thoroughly answering all those questions. I know everyone really appreciates that. And for this amazing presentation. So thank you again. And thank you also for everyone joining today's session. Again, make sure you fill out the Google quiz. It will close at 6 p.m. and you need to get 2 out of 3 questions right in order to get your certificate. So again, there's not going to be any retakes or anything. This is just so we can be as legitimate as possible and make sure that you're paying attention. Our next 2 events will be with 2 Forkner, a PAC OBGYN, on October 6th at 7 p.m. and with Rosevine Azap, a second-year medical student at OSU at 6 p.m. That is on October 15th. So 2's event will count as virtual shadowing. So if you want to get the certificate, make sure to attend. And thank you again so much, Chrissy, for speaking today. I hope you have a wonderful day.
Thanks, guys. You too. Good luck, everybody.